Good afternoon, everyone. Welcome to this webinar entitled Sports Ultrasound of the Midfoot, presented by Dr. Jonathan Finnoff. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to describe the sonographic features of a tarsal fracture, identify sonographic abnormalities associated with a spring ligament sprain, discuss the sonographic evaluation of Lisfranc joint sprains, and understand the etiology of jogger's foot. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Jonathan Finnoff and Darcy Belito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded one CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Jonathan Finnoff.
Hello, everybody. I'm pleased to be here, and thank you very much to the AIUM and AMSSM for inviting me to give this presentation. I'm going to get everything set up here, so you should see my screen now. And I'm just going to move this chat box over to the edge here. All right, so I'm going to be talking to you about sports ultrasound of the midfoot. There we go. I don't have any specific disclosures related to this particular topic, and my learning objectives you just heard in the very nice introduction that was provided. So we'll jump right into the first case. So this is a 22-year-old athlete who presents with left lateral foot pain after experiencing an inversion stress while playing soccer. They felt a pop at the time of the injury and immediately developed swelling, ecchymosis, and they had tenderness to palpation over the base of the fifth metatarsal. So the question is can you ultrasound this? Can ultrasound evaluate this particular injury? So midfoot fractures have had extensive research regarding the utility of ultrasound to diagnose them. And they're best at evaluating flat bone surfaces such as the diaphysis or metaphysis. And for these, they actually have quite high sensitivity and specificity at 90% and 96% respectively. And there are a lot of different advantages of ultrasound relative to other imaging modalities. Obviously, if you're doing sports medicine, which is one of the things we're talking about here, and you're doing ultrasound, it's a whole lot easier to have your ultrasound on the sideline than carrying your x-ray in your bag to the sideline of the game. So you have immediate access to this nice portable ultrasound device, and you can take a quick look at somebody's injury and make the diagnosis right there on the sideline. It actually also can be used to identify occult or unsuspected fractures. So they have an injury in an area, they have pain, you're taking a look at it, and ultrasound can identify some of those occult injuries that you didn't suspect as a fracture. And it can also detect stress fractures, which is fantastic since we all know that that radiographs take quite a while in order to become positive. So what are the findings that ultrasound has when you're looking at a fracture. Well, number one, on the cortex, you're going to see discontinuity. So you're going to see a fracture in that area, a gap. You might see a step off if it's malaligned or displacement. And you'll also see in the adjacent soft tissues a hematoma. So it's going to hemorrhage in that area. The tissues are going to swell around it, so you'll have edema. And you'll also have hyperemia, particularly in that early phase of healing. And as you go through healing, you're going to have that hemorrhagic phase initially, but then you're going to form a soft callus. And you can see that in the upper picture right here over the top of this fracture site. And then it's going to eventually form into a hard osseous callus. So looking at the research, there was a nice prospective study done by emergency room physicians, and they looked at patients who were over 14 years old who had tendinous palpation in their fifth metatarsal. And they compared the sensitivity and specificity of ultrasound versus X-ray in the hands of an emergency room physician to detect a fracture in the fifth metatarsal. So they had 84 subjects that ended up being enrolled in this study, and they identified 33 fractures on X-ray and ultrasound. There was only one fracture that was diagnosed by X-ray, but not by ultrasound. So what they found is that for fifth metatarsal fractures, ultrasound had a sensitivity of 97.1% and a specificity of 100%. The positive likelihood ratio was of infinity, and negative likelihood ratio was 0.03. Another thing is they looked at the displacement measurements between X-ray and ultrasound, and they're within a millimeter of each other. So they're very, very similar. So their conclusion was that ultrasound is a sensitive and specific test for fifth metatarsal fractures. Another emergency room study looked at patients between 5 years old and 55 years old who had a suspected metatarsal fracture. So rather than just the fifth metatarsal, this is all of the metatarsals. And they had the ultrasound performed by an emergency room physician or emergency medicine physician, so the point of care ultrasound. And they compared that to foot radiographs interpreted by a radiologist. And they looked at the sensitivity and specificity and found that, again, very highly sensitive and specific for metatarsal fractures. And even more importantly, the fractures that require surgical intervention or reduction had an incredibly high sensitivity and specificity of nearly 100%, which is important when you're doing your clinical decision-making process. Another study was performed retrospectively, and ultrasound had detected occult fractures in several patients. So they had negative initial radiographs, but the ultrasound identified a fracture. And they looked back through this case series of 24 patients, and they found that 8 of these occurred in the calcaneus, 6 in the metatarsals, 3 in the talus, 3 in the navicular, 2 in the cuboid, 1 in the cuneiform, and 1 in the lateral malleolus. And so really in a multitude of different locations. And the fracture ended up being confirmed either by reinterpretation of the X-ray or another imaging modality, such as a CT scan or a bone scan. And so again, what this shows is that ultrasound actually has very high sensitivity for identifying fractures, even ones that are difficult to detect with normal radiographs. Now, most of you are probably very familiar with the os perineum. It's a small sesamoid bone located in the peroneus longus tendon near the edge of the cuboid as the peroneus longus wraps around the lateral aspect of the foot. It's present in 20% of adults. It's usually bilateral, and it can be bipartite. But in ones that are unipartite or in a bipartite os perineum that has a cartilaginous bridge between the two parts, there can be a fracture in that area. And the fracture can occur with or without a peroneus longus tear. And if you misdiagnose this fracture, it can lead to, of course, ongoing pain, but also some ankle instability and potentially a perineal compartment syndrome. So these are important to identify. A study looked at ultrasound, radiographs, and MRIs in patients with confirmed os perineum fractures compared to controls. And what they discovered is that if the fracture is separated, if the two fragments are separated by greater than 6 millimeters, then the osperineum fracture is associated with a full thickness peroneus longus tendon tear, which obviously is very clinically important. And if the fragment was less than 2 millimeters, it was either a bipartite osperineum or a non-displaced fracture. So they didn't have any significant associated tear of the peroneus longus. So remember that number, the 2 millimeters. Greater than 2 millimeters, start thinking about more significant injury. Greater than 6 millimeters, look for a complete tear of that peroneus longus. Another study looked at the anterior superior calcaneal process fractures. So here on the right, you can see that anterior superior process of the calcaneus. And this represents 3 to 23% of all calcaneal fractures. And this is in the area of the calcaneocuboid. So here's the calcaneus and the cuboid and the calcaneonavicular articulations. And there's a ligament that spans this area, the bifurcate ligament. And so here's the anterior process. And you can see part of the bifurcate ligament goes between the calcaneus and the navicular, and the other part goes down to the cuboid in that area. So if you have an inversion, adduction, and plantar flexion stress to the ankle, then that will stress that bifurcate ligament and can cause an avulsion fracture of the anterior superior process of the calcaneus. You can also have a compressive injury where your foot gets abducted, compressing that calcaneocuboid joint and causing a fracture of that same area. So normally, if this is the anterior superior calcaneus process, and here's the cuboid, and here you can see this ligament going between the two, so the bifurcate ligament right there. And this is a fracture where you can see this bony portion that was avulsed off of the anterior superior calcaneal process. And here's a confirmatory x-ray showing that. So you can definitely identify those with ultrasound. Next case is an 18-year-old football lineman, and they present with midfoot pain. Another player during the game rolled onto the back of this patient's foot while their foot was in a plantar flexed position. So if their foot was plantar flexed, as the other lineman rolled up onto the bottom of that foot, it caused hyperflexion of the ankle. The patient had immediate onset of pain in the midfoot and couldn't weight bear in the area. And on physical examination, they were tended to palpation over the dorsal midfoot and had pain with a midfoot stress test. They also had pain with dorsal and plantar manipulation of the first and second metatarsals relative to one another. So hopefully many of you already have in your minds what this particular diagnosis is, so can ultrasound be used to evaluate this injury? This is a Lisfranc joint sprain, and it represents about 0.2% of all orthopedic injuries, but it's a significant injury. The mechanism of action is either an axial or a rotational force on a fixed plantar flexed foot. So it's this exact mechanism I was talking about with a football lineman who has another player roll right up onto the bottom of their foot. 20% of them are misdiagnosed or unrecognized in the emergency room. So really pretty frequently these are missed. And if they're missed, they can lead to chronic pain, functional limitations, and eventually osteoarthritis. So looking at the Lisfranc joint, the second metatarsal is the keystone of the midfoot arch in the foot. And there is a ligament in this Lisfranc joint that goes between the medial cuneiform and the base of the second metatarsal. So there's a dorsal, a plantar, and an interosseous Lisfranc ligament in this area. And with ultrasound, you can look at the dorsal Lisfranc ligament. So conventional imaging for these injuries include weight-bearing radiographs, a CT, or an MRI scan. But ultrasound can reliably image the dorsal Lisfranc ligament. So Woodward's and the group out of University of Michigan with John Jacobson, they did a retrospective study of 10 patients who had a unilateral Lisfranc joint injury, and they compared it to the imaging on the contralateral foot in 5 of these patients. The asymptomatic feet the Lisfranc ligament is hyperechoic. It's uniform in dimensions. Its thickness is typically around 1 millimeter. And there's less than 1 millimeter separating the medial cuneiform and the second metatarsal base. So symptomatic feet in this particular cohort were divided into 3 groups. And the first group had no significant sonographic abnormalities. And they all ended up having normal clinical follow-up and radiologic evaluation. So this would essentially equate to a grade 1 sprain. So they were symptomatic in the area, but it was more of a microscopic as opposed to a macroscopic injury. So here you can see a Lisfranc ligament going between the medial cuneiform and the base of the second metatarsal, it's the base of the second metatarsal and medial cuneiform. Now the second group had hypoechoic swelling. So here you can see a thick hypoechoic ligament. And the dorsum of that ligament is convex. So you can see how it's convex, facing up more superficial. The distance, though, between the second metatarsal base and the medial cuneiform is still very, very narrow. So there's no separation in this area. So this would be considered a grade 2 type of sprain. And they didn't have any widening on weight bearing. And they had normal confirmatory radiographs. And these people had an uneventful clinical course. So they responded very well to non-operative measures. The third group had hypoechoic or non-visualized dorsal Lisfranc ligament, so a gap in the area where the ligament should have normally been. And the distance between the medial cuneiform and the second metatarsal base was greater than 2 millimeters, so really quite widened compared to the others where they were 1 or less millimeters in width. And when the person weight bared in that area, you can see how from here where they're non-weight bearing to here where they're weight bearing, there's a significant increase in that distance. The complete Lisfranc ligament with disruption was confirmed either by CT, MRI, or surgery. So ultrasound was highly sensitive and specific for identifying this specific injury. Now let's move on to another ligament injury in the midfoot, the spring ligament. And the spring ligament, or the calcaneonavicular ligament, actually has 3 components that form that ligament. There's a superomedial component here. There's an inferoplantar and a medioplantar aspect of the ligament. The superomedial calcaneonavicular ligament articulates with the talar head via a fibrocartilage. So if this is the talar head, then there's a fibrocartilaginous area between the ligament overlying it and this area. And this is called a spring ligament fibrocartilage complex. And then sitting in between the ligament and the overlying posterior tibial tendon is some loose areolar tissue to allow mobility of that tendon as it rubs across that area. So you can see with ultrasound the superomedial aspect, just coming back a couple of slides here. So you can see this superior medial aspect of the calcaneonavicular ligament. So if you put your transducer over that medial aspect of the foot, here's the navicular, here's the calcaneus, here's the talus, and here you can see this nice calcaneonavicular ligament right there, and sitting right on top of it is the posterior tibialis tendon. So the spring ligament stabilizes the medial longitudinal arch of the foot and helps support that talar head. So when you have an injury in that area, the talar head drops down into a flexed position, resulting in a flat foot deformity, and the hind foot will become more of a valgus malalignment, so the calcaneus will stick out laterally. And often when this happens, you'll have chronic posterior tibialis dysfunction associated with this injury. And if you look at ultrasound for evaluating this region, there's a 95% concordance between MRI and ultrasound findings for spring ligament pathology. So again, ultrasound is very highly sensitive for identifying this significant injury. So the normal superomedial spring ligament measures less than 4 millimeters in its proximal and distal aspects. And as you have an injury in this area, it becomes thickened and hypoechoic. And most of the injury actually occurs more on the distal aspect. And so you'll see more thickening in that distal aspect. So normal, it is essentially doubling in size. So it goes from 3.6 millimeters up to 6.1 millimeters in thickness. And here you can see a normal spring ligament in the two areas that you're making the measurements. And here you can see an abnormal spring ligament. One of the pitfalls when you're trying to use ultrasounds to evaluate that superior medial bundle of the spring ligament is an accessory navicular. So if you have an os navicularis or an accessory navicular, another name for it, in that area, then you can't see through that ossification, and so you can't adequately image the spring ligament with ultrasound. So the third case, a 56-year-old woman with insidious onset of midfoot pain. She had a history of a midfoot sprain when she was far younger, and more recently she's developed this painful stiffness with activity initiation. But after she moves around a little bit, it feels quite a bit better. But if she does too much activity, then it starts hurting more. With midfoot stress test, that causes pain. She has tenderness palpation over the dorsal medial foot. So can ultrasound be used to evaluate this particular problem? So this patient has midfoot osteoarthritis, and it's really quite common, but is variable between people. The most common place for osteoarthritis is actually in the first metatarsophalangeal joint, which is not in the midfoot, but it can certainly happen in the midfoot as well. And there are a variety of different risk factors that predispose to developing osteoarthritis in the midfoot, and these include obesity, prior trauma, which was the case for this patient I was just talking about, malalignment, posterior tibialis dysfunction. So if your posterior tib is dysfunctional and that superior medial band of the spring ligament, then they're going to get calcaneal valgus. They're going to have more of a flat foot, and that's going to put abnormal stress in their foot. Smoking and family history also predispose to osteoarthritis. So the sonographic findings of osteoarthritis in any joint include a joint effusion, synovial hypertrophy, osteophytes in the area and cortical irregularities, joint space narrowing, malalignment or subluxation. You may see loose bodies, and you potentially can see hyperemia in the area. Interestingly, ultrasound is 2 times more sensitive than clinical examination for detecting pathology in a joint. So just because somebody doesn't have symptoms in an area doesn't mean that they don't have degeneration already starting, and ultrasound is highly sensitive for identifying preclinical or subclinical osteoarthritis. The next case is of a 34-year-old female marathon runner who presents with medial midfoot pain. This pain had an insidious onset and was increased with weight-bearing activities. The patient reported having local edema in the area and was tended to palpation over the distal insertion of the posterior tibialis tendon. So, can ultrasound be used to image this particular problem? Posterior tibialis tendon pathology is really quite common. The posterior tibialis tendon, as you can see here, comes down posterior to the medial malleolus and then runs in the anterior aspect or it runs anteriorly across the medial aspect of the hind and midfoot and inserts in the navicular tuberosity, the cuneiforms, and the base of the 1st through 4th metatarsals. It's most common in middle-aged females. So if somebody is far younger than that and presents with posterior tibialis tendon problems, then you want to think of an inflammatory disorder, so a seronegative spondyloarthropathy or lupus or rheumatoid arthritis. And if somebody is older, then you're thinking more of a degenerative rather than an inflammatory condition. There are multiple different contributing factors, again, to this condition, similar to osteoarthritis. So anything that leads to hyperpronation, again, spring ligament problems, frankly, the posterior tibialis dysfunction can exacerbate. It's almost like a vicious cycle where as you have posterior tib dysfunction and you start having more pronation, it puts more stress on that posterior tib and can cause more pathology. Obesity, prior steroid injections, and this is one of those tendons that I'm more hesitant to do a corticosteroid injection for because it just loves to tear. So it's just like doing a corticosteroid injection around the patellar tendon or the Achilles. Posterior tib is one that likes to tear, so I stay away from steroids for this particular problem. Diabetes mellitus, hypertension, and ligamentous laxity also predispose to this condition. So there's a continuum of tendon pathology. It often starts with tenosynovitis and then progresses, which is more of an inflammatory condition, and then progresses to tendinosis, which is more of a degenerative condition. And some of this can be due to hypovascularity. And there's a hypovascular zone of the posterior tibialis tendon that starts a centimeter above the medial malleolus and extends to a centimeter below the medial malleolus. That's also a point where the posterior tibialis tendon is changing direction, and so there's a fulcrum in this area, and it puts added stress on the posterior tibialis tendon. As you have more and more tendinosis, you'll eventually start developing partial thickness tears. A type 1 tear is a fusiform, you have fusiform tendon enlargement with intrasubstance degeneration and longitudinal tears. And a type 2 tear is where you have more significant tearing and you start to have partial thickness transverse tears as opposed to just longitudinal tears. So the tendon, instead of being big and thick, is going to start actually looking thinned in this area because you have less fibers bridging the area of your tear. And these people have really quite decreased function and will have more of a flat foot deformity. And then the final pathway, or the final worst problem that you can get if you go through this whole continuum, is a full thickness tear or a type 3 tear of the posterior tibialis tendon. If you have posterior tibialis tendon pathology, that's going to increase stress on your spring ligament complex, which will result in ligamentous strain and chronic sprain in this area. You're also going to have increased stress on the sinus tarsi ligaments, and that's the talocalcaneal interosseous ligament and the cervical ligament in the area. If you have injury to these secondary structures, then that really suggests that the problem is chronic and not an acute problem. So from a radiologic standpoint, there are some things you can look for. One is around that medial malleolus, you can get some cortical irregularities. On the navicular insertion, you can get cortical irregularities and an enthesophyte at that navicular insertion. And what I was talking about, what I was just referring to a second ago, is that you get an ossification at the medial malleolus area, where it forms a ridge just anterior to that posterior tibialis tendon, and that is commonly associated with posterior tibialis tendon dysfunction. From a sonographic standpoint, the tendon is going to be thickened. Now, normally the posterior tibialis tendon is roughly 2 times the size of the flexor digitorum longus. But in this case, it's going to be greater than 2 times the size of that flexor digitorum longus. It's going to be hypoechoic and heterogeneous. There's going to be surrounding synovial hypertrophy, and you may have increased fluid within the tendon sheath. Now, it's normal to have a small amount of fluid in the tendon sheath. It's usually less than 2 millimeters, and it's not circumferential, so it's just in one area of the posterior tibialis tendon sheath rather than surrounding the entire tendon. So if you have greater than 4 millimeters of fluid or it's circumferential around the tendon, then that is pathologic. You can see intrasubstance tears, hyperemia, and you can obviously see full thickness tears. The accessory navicular I mentioned before when we were talking about the spring ligament, and there are 3 types. The first type looks like a little sesamoid bone in the area, and that's represented in this X-ray and this ultrasound. Those are pretty easy to see, and they usually don't cause any symptoms. Type 2 is larger, it's well corticated, and it has a fibrocartilaginous synchondrosis between the accessory navicular and the navicular proper. And then type 3 is where that accessory navicular essentially gets incorporated into the rest of the navicular. So you have an ossified bridge across that area. So the ones that typically give people problems are the type 2. And you can either have degeneration of that synchondrosis, or you can break that synchondrosis of the type 2 os naviculari. So things that suggest that you have a symptomatic type 2 os naviculari is cortical irregularities in the region, heterogeneous echotexture between the two bones, separation or diastasis between the two bones, or fluid surrounding that synchondrosis and the adjacent patellar tendon. So moving on to case 5, this patient was a 36-year-old female runner. She presents with medial plantar foot pain. That pain was a burning, lancinating quality, and it radiated down to the first and second toes. And it would occur predominantly with weight-bearing activities, and in this case for her, it was running. On physical examination, she had significant pes planus that was dynamic. She had tenderness to palpation over the knot of Henry, which I'll talk about in a second. She had a positive Tinel sign in that area, and her symptoms were provoked with ankle dorsiflexion and eversion. Now, just to talk a little bit about some of these different things. So dynamic pes planus, when somebody walks, if they have a high arch and it's relatively rigid, then that type of foot tends to be predisposed to stress fractures. It does not absorb shock. They often have a tight gastrosoleus complex. With dynamic pes planus, you're kind of going in the opposite direction, where as they walk, that medial longitudinal arch collapses down. But if you have them walk on their toes, their arch will reform into a nice normal arch. And what that means is it's a flexible deformity of their foot. It's pronation rather than a fixed flat foot deformity. And this flexible flat foot, when they go up onto their toes, when your great toe extends, it tightens up your plantar fascia and it locks out the midfoot, so you have a rigid lever arm to propel yourself forward, but that reforms the arch. So when you're walking, looking for that dynamic pes planus is important. The knot of Henry is in the midfoot, where the flexor digitorum longus tendon crosses over the top of the flexor hallucis longus tendon. And I'll show you some ultrasound pictures of that in just a second. A Tinel sign is when you tap over the nerve and it causes an electric sensation radiating down the foot. So can ultrasound be used to evaluate this particular problem? So here I have a nice picture of the midfoot or plantar aspect of the midfoot. So back here, this is the tibial nerve, and it separates into the medial and lateral plantar nerves. And the medial plantar nerve is coming here along the medial aspect of the midfoot, going underneath the abductor hallucis muscle, and then it divides into the different digital nerves more distally. The knot of Henry is just deep to this area. So here you can see the flexor hallucis longus tendon coming back, and the flexor digitorum longus tendon coming across. And so right in this area is where those two tendons cross, and that is the knot of Henry. And you can see how this medial plantar nerve sits right on top of these tendons in the area of the knot of Henry. So the medial plantar nerve provides motor innervation to multiple different muscles in the foot. It also has a sensory distribution in the medial aspect of the foot and medial toes. Entrapment of that particular nerve is called jogger's foot, which is what this patient had. So there are several different sites where the medial plantar nerve can get entrapped. The first site, more proximally, that the tibial nerve can get entrapped is under the tarsal tunnel, or the flexor retinaculum in the tarsal tunnel. But if they have an early division of the tibial nerve into the medial and lateral plantar nerves, you could certainly have a selective entrapment to the medial plantar nerve as it goes underneath this flexor retinaculum. Then as that medial plantar nerve comes down distally and it crosses underneath the abductor hallucis muscle, it can get entrapped in that fibroosseous tunnel. And then as it goes down further in the area of the knot of Henry, it can get entrapped in that spot as well. Some different predisposing factors. So if the patient hyperpronates, then you can see is that calcaneus everts, it's going to put traction across the medial aspect of the ankle, all of the structures there, including the tibial nerve, the medial plantar nerve, and lateral plantar nerve. So hyperpronation is going to be a problem, or a flat foot deformity. Hypertrophy of the abductor hallucis abductor hallucis muscle. So if this muscle is a big muscle, as that nerve crosses underneath it, that's going to cause problems. You can also have fibrous bands in that area that can compress the nerve. And people who get orthotics that have too high of an arch can press right up against the nerve and cause compression and pain. So signs and symptoms of jogger's foot include exercise-induced neuropathic pain along the medial longitudinal arch of the foot radiating down into the first and second digits. That's exacerbated by shoes or orthotics with a high arch, or if they have significant pronation during weight bearing. On physical examination, these patients are going to have tenderness to palpation and a positive Tinel sign over the entrapment site. They're going to have pain when the ankle is dorsiflexed and everted, because that's going to put traction on the nerve as it goes posterior to the axis of rotation of the ankle and along the medial ankle. And they're going to have pain during toe walking, because when you go into toe walking, that's going to put more tension onto the abductor hallucis muscle. They rarely have neurologic deficits when you're doing your physical examination. So the Tinel sign is the main thing that you'll see from a neurologic standpoint when you tap it. They'll get an electric sensation in the area of that entrapment. So you can get radiologic and electrodiagnostic studies, but they're often normal. And this is where ultrasound comes in, and I think it's really fantastic for looking at these small entrapments. So the nerve itself in the site of entrapment is going to be compressed at that site of entrapment, but proximal to it, you're going to have hypoechoic swelling. So axoplasmic flow, and as proteins and fluids are being taken down from the cell body peripherally out to the dendrites at the end of the axon, they're going to get blocked in this area where you have compression, and so it's going to cause proximal swelling in that area. It's kind of a bottleneck of the axoplasmic flow. And you may see adjacent pathology that's contributing to compressing the nerve, such as tendinopathy or tenosynovitis or an adjacent ganglion cyst. I'm just going to have you look over here at this ultrasound. So this is plantar, this is dorsal, and if you look right in this area, this is the sustentaculum tali. And so coming right over the top of the sustentaculum tali in this area is the flexor digitorum longus. Right in this area underneath the sustentaculum tali is going to be your flexor hallucis longus. And sitting right next to them right here is the medial plantar nerve. And as I come down distally, so here's the medial plantar nerve. Here are the two tendons starting to cross over one another. So you can see that flexor digitorum longus coming over the top of the flexor hallucis longus with the adjacent medial plantar nerve, and over here is the lateral plantar nerve. And right here, look at all of this swelling and all this swelling in this area. So this is the knot of Henry, and this person has significant tenosynovitis of the flexor digitorum longus and flexor hallucis longus at the knot of Henry, and it is pushing against this overlying medial plantar nerve. Right here, you can see a still image of that exact same thing. So tendons crossing over one another and medial plantar nerve right next to it. So one of the things you can do if you suspect that they have a jogger's foot and compression of that medial plantar nerve is a diagnostic nerve block in the area and see if that alleviates their pain. So here you can see the same picture. Right in this area is the flexor digitorum longus, flexor hallucis longus, medial plantar nerve. And so up into this picture, you can see a nerve in the tendon sheath of the flexor digitorum longus. Then the nerve is advanced underneath that medial plantar nerve right here, so doing an injection around that medial plantar nerve. And in this particular case, because I wasn't doing it for diagnostic purposes, but more for therapeutic purposes, the needle was then redirected into the flexor hallucis longus tendon sheath. So all three of these areas were injected with one needle pass. So the next patient comes into the office and says, "Doc, I have a lump on the bottom of my foot." And this had an insidious onset. It developed over several months. There wasn't any particular injury in the area, but it hurts. It hurts when the patient was doing weight-bearing activities when this area is being pressed on. On physical examination, they were tentative palpation directly over the lump. There was no surrounding erythema or ecchymosis. And while the lump was attached to the deep tissues, it was not adherent to the overlying skin, so the skin was mobile over the top of that lump. So what could this be, and can ultrasound be used to look at this particular pathology? So this patient has plantar fibromatosis, and this person had a single one, so it was a plantar fibroma. This was first described by Lederhose back in 1897, so a long time ago. It's a proliferative disorder of mature fibroblasts and is associated with multiple different conditions, including diabetes, epilepsy, which that's an interesting one to me. I'm not sure why epilepsy would necessarily cause plantar fibromatosis, but it's higher in people who have epilepsy. Prior trauma to the area, older age, low body weight, smokers, manual laborers, and people who have a family history of plantar fibromatosis. So there is a hereditary component. It often happens in the medial or central aspects of the plantar fascia, and it's often asymptomatic unless there is external compression. So again, if they have orthotic and it has a relatively high arch and it's pushing right up on that plantar fibroma, that can cause pain. Or if it's compressing adjacent structures, such as a proper digital nerve. So there are three stages of the formation and essentially dissolution of the plantar fibromas. The first one is a proliferative phase where it's forming. Then you have an involutional phase where the nodule is fully formed and starts to degenerate and the tissue contracts in the residual phase. So here you can see that there's an MRI of a plantar fibroma, and here is an ultrasound of that same structure right in this area. So they typically are hypoechoic. They're elongated in the sagittal plane. They're in the superficial portion of the fascia. They're usually located in the medial or central aspects of the plantar fascia, so not as commonly over in the lateral band. And they don't have any associated hyperemia. In juveniles, they tend to be a little bit more aggressive and more painful, and they form more fibromas than in adults. You can try, from a treatment standpoint, giving them orthotics and building a little relief or cutout in the orthotic so that it doesn't press against the fibroma. You can do an intralesional injection with steroid, which will cause some atrophy of the area, and that might make a difference. And you can excise it, but there's a high recurrence rate of these fibromas when you cut them out. So the take-home points from this presentation. Number one, ultrasound is highly sensitive and specific for many different foot fractures. And it can be used to assist with differentiating non-operative versus operative fractures. So you can see that displacement or malalignment well with ultrasound that helps you make in your clinical decision-making process. If somebody has a mechanism of injury that fits with the Lisfranc joint sprain, and you scan the base of the second metatarsal and measure the distance between the base of the second metatarsal and the adjacent medial cuneiform, and they have a width of greater than 2.5 millimeters. They have anechoic or hypoechoic ligament, and when they weight bear, that width increases. All of that is going to indicate that they have a significant Lisfranc joint sprain that requires surgical intervention. So that would indicate a surgical referral. Spring ligament injuries frequently coincide with posterior tibialis tendinopathy. So when you're looking at the posterior tibialis tendon, you should also be commenting on the underlying superior medial band of the spring ligament. And neuropathic pain of the medial plantar foot that extends into the first and second toes suggests compression of the medial plantar nerve in the midfoot. There are a lot of learning gaps still, or research gaps, and here are some recommended research studies in the future. So Number one, ultrasound has very limited studies looking at medial plantar nerve entrapment. So we need to do some well-designed studies to really identify the role and clarify the role of ultrasound in the diagnosis of this condition. I think that's a really important one, considering almost all of our other radiologic studies are negative, as are electrodiagnostic studies. So ultrasound really could be a key differentiator for that particular condition. Research, number two, research is required to determine the role of ultrasound in the evaluation of the inferoplantar and medioplantar portions of the spring ligament. Because to date, the only portions of the spring ligament that have really been evaluated with ultrasound is the superior medial portion of the spring ligament. And number three, well-designed prospective studies are required to confirm the role of ultrasound in the clinical and diagnostic evaluation of Lisfranc joint sprains. Since the single study that looked at this only had 10 patients in the study, and it was retrospective. So thank you very much for your attention. I'm going to slowly run through the bibliography here while I take questions. You can submit your questions by typing them into the box. There's a chat box, and so if you type your questions into that area, you should be able to get those sent to me. Let's see. I'm trying to access that question box. It's very small for me. So, any thoughts on hydrodissection versus steroids of the medial plantar nerve for people who don't improve with physical therapy and conservative measures? So, I certainly think that a corticosteroid injection is a reasonable treatment in that area, and most people, when they're doing hydrodissections, are putting some corticosteroid in that hydrodissection. I have really seen very limited research at this point comparing a hydrodissection alone to a corticosteroid injection alone. Almost all of the hydrodissections in the research that I have read have included corticosteroid. So in general, I think that particularly if you have an adjacent tenosynovitis, I would probably include corticosteroid. But on the positive side, if you do a hydrodissection alone, at least you're getting diagnostic information, and if there is some type of entrapment, maybe it will free up that entrapment and allow the nerve to move a little bit more freely. But a lot of times these are compressive, so you might want to consider using a corticosteroid with it. So have you had any good response using Prolo or PRP for posterior tibialis tendinopathy or tendinosis? And so I have, just like any other treatment, I don't think that there's a miracle cure for this, and these can be really difficult. So I think you need to address the underlying factors. They need to lose weight. I think that using orthotics can be helpful, particularly the UCBL orthotic, which really controls that hind and midfoot. Strengthening their foot intrinsic and ankle support musculature. There's some literature supporting eccentrics for the posterior tibialis tendon for posterior tibialis tendon dysfunction. But if those aren't working, I think that a proliferant of some type is a reasonable treatment option, considering corticosteroids are probably relatively contraindicated for this particular condition. So next question, any thoughts on grading the zone 1, 2, or 3 using ultrasound for base of the 5th metatarsal fractures? So I haven't actually come across any specific literature on that, but I think that you absolutely could grade those zones using ultrasound, since you can identify in a long axis where that fracture is in relation to the base of the 5th metatarsal, its metaphysis and the diaphysis. So I think that ultrasound probably could, and that would be a great low-hanging fruit study if somebody wanted to pursue that. Let's see. I'm heading down here looking at some of these other questions. You mentioned measuring the hypoechoic fluid of the posterior tibialis tendon sheath. This was in millimeters. Is this the diameter or the distance from the tendon to the perimeter of the sheath? It is the latter. So if it's circumferential, that's pathologic. If we were measuring the amount of fluid in millimeters, it's from the tendon to the tendon sheath, and so it's the wad of fluid in that area. Great question. What are the common features of stress fractures on sonography? So what you're going to see in a stress fracture is you'll often see a periosteal reaction. So you'll see thickening of the periosteum with or without a cortical break, and you'll see hyperemia in that area. So those are the earliest findings, and then of course after it breaks, then you get the standard findings that you get with other fractures that I discussed in the lecture. Any cases on lateral foot ligament injuries? So this specific presentation was really just focused on the midfoot, and so I'm assuming by the lateral foot ligaments you're probably talking more about ankle ligaments. If you're talking about foot ligaments, we talked about the bifurcate ligament, and so that's the lateral foot ligament that's relevant to clinical setting, and so that usually causes the avulsion of the anterior superior process of the calcaneus. So that's the only lateral foot ligament injury that's common that I talked about. How good does the anterior talofibular ligament injury? Oh, so this is another one about the ankle. And so the ultrasound is great at identifying sprains of the anterior talofibular ligament. So you can use the ultrasound to not only grade the severity of injury of the ATFL, so similar to what we were talking about with the Lisfranc ligament. It can look normal, but can hurt when you push on it. So clinically, they have a grade 1 sprain, but it's intact and it looks normal, so it's more of a microscopic injury. They can have a partial thickness tear or a big swollen, thickened ligament that's hypoechoic. That's more along that grade 2, and then a grade 3 is where it's in discontinuity. And at the same time, you can do a dynamic evaluation where you do an anterior drawer test to the ankle and see if there's excessive anterior shifting of the talus relative to the fibula. So it's really good for that. Next question, what is the role for ultrasound in tenosynovitis from gout? Well, that's a really good question. Now, I don't see a ton of rheumatologic conditions, but certainly uric acid crystals you can see on ultrasound, so it looks like a complex effusion, and so with the tenosynovitis associated with gout, I would anticipate that you would see a complex effusion as opposed to a simple anechoic effusion around the tendon, and of course they would have a history that would be consistent with it, no activity that provoked it, sudden onset, severe pain, history of gout, and so on. But I don't know specifically from my standpoint, I wouldn't be able to tell you if there are very specific criteria that differentiates gout from other conditions on ultrasound for tenosynovitis. Any cases of talocuneiform injuries? So absolutely. I mean, any of the joints can either get sprained, or you can also get osteoarthritis in these joints. And so, based on what the patient is presenting with, that helps you, it points in the direction of suspecting a specific type of injury. But for instance, if a patient was similar to the patient I presented in this presentation where they're 54, insidious onset, prior history of trauma when they were young, you're really thinking about osteoarthritis in the area. And frequently midfoot osteoarthritis is kind of hard to identify on x-ray because of the overlapping bones. And so if you identify where they hurt, it hurts in a place where you push, you can look at it with ultrasound and see what lives there and whether there is an identifiable abnormality, whether that's a sprain or osteoarthritis. So I didn't specifically talk about that, but yes, you can have pathology there and you can evaluate it with ultrasound. What are your thoughts on time to perform ultrasound? So sort of the time-benefit ratio, and is the information usable for direction of interventions? What about the cost of doing ultrasound versus other radiologic studies? You know, and in my opinion, I think this is one of the things that really differentiates ultrasound from other radiologic studies. So, you know, what's the time? Well, if it's a relatively focal abnormality and you're doing a limited diagnostic ultrasound to specifically look at one or a few structures, it's going to be very, very quick. And you're going to do it, and since you did it and you did the history and physical examination, and you're suspecting a specific condition and you're ruling it in or out, ultrasound is not only going to be quick, it's low price, and you give the patient feedback immediately, and it also can help direct your care. Sometimes that's going to be saying, okay, well, you have significant tendinopathy, we need to be doing X, Y, and Z treatments, or it might be, well, you know, you have significant tendinopathy, and I would recommend this intervention that ultrasound can now guide. And I definitely think that when you have pathology in a specific area, one of the great things about ultrasound is when you guide a procedure, you know you're putting the medication in the spot of pathology, and you're treating it to the best of your ability. So I'm a strong proponent of using diagnostic ultrasound for its convenience, for its time effectiveness. It's low cost, there's no radiation, it's portable, and you can guide interventions with it. So I'm biased because I like ultrasound, but that's my opinion. Would the diagnosis of any of these different lesions benefit from more objective quantitative ultrasound techniques? I think it really depends on the condition. So some things in ultrasound are very quantitative, and some things are more qualitative. And we're developing more things with ultrasound that are going to become more quantitative. So for instance, you know, at some point, maybe we're going to be measuring more of the stiffness through ultrasound elastography of various tissues and providing a quantitative measurement of that stiffness, and then monitoring recovery based on the tissue stiffness, or determining the injury severity or pathology severity based on that stiffness. There are some different grading scales that are quantitative, you know, how much of the ligament is torn, how much of the tendon is involved, how large is the tendon in a measurement compared to the contralateral asymptomatic side and stuff. And I think all of that is very, very important. But I believe strongly that in addition to the quantitative stuff, the qualitative information is also important. So both of those are going to contribute to your overall picture for that patient, the information. So how frequently do you identify an accessory navicular that interferes with spring ligament visualization? Well, so the accessory navicular, the incidence of an accessory navicular, depending on where you read, is going to be probably between 2 and 20%, so in the lower range. But it's not that uncommon. And so it's not that uncommon that it really obstructs your ability to identify the underlying spring ligament. So anybody who has one of the three types of osteonavicularia, it's going to be difficult to see the underlying spring ligament. So it's just not that uncommon that can be an issue. Can you describe probe placement to evaluate the spring ligament? So for long axis, what I'm doing is I'm identifying with palpation or with ultrasound the sustentaculum tali. And then once I've found the sustentaculum tali, I'm anchoring the proximal aspect of the transducer over that, and then I put the distal aspect of the transducer over the navicular, over the medial aspect of the midfoot. And so going between that sustentaculum tali and the navicular should be your spring ligament. And it's kind of bridging superficial and over the top of the talus in that region. Then once you've identified it in long axis, you can certainly flip into short axis and look at the same area. And that wraps up the presentation.
Thank you very much, Dr. Finnoff. And on behalf of the AIUM and the AMSSM. Our thanks to all of you who participated in today's webinar. Please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and that you'll join us again for future webinars. So long, everyone.